My patient name ABC, age 22 month, sex female child, informant with Hindu as a religious. Date of admission in the hospital is 8 of July 24. Date of examination is 15 July 24. Child come to hospital with chief complaint of fever for 6 days and increased frequency of urination since 6 days. History of present illness. A 22-month-old female child, apparently well 6 days back, presented with fever which was mild on onset for 2 days, then high grade 103 Fahrenheit associated with chills, intermittent, relieved temporarily by medication. Child was active and accepting orally well in interfebrile phase. Parents also complain of increased frequency of urination with diaper change frequency of 10 to 12 times a day, normally which was 6 or 7 times a day. Diaper was fully soaked and associated with foul smelling urine. There is no complaint of vomiting, flank pain, cry during micturition. There is no history of cough and cold, no history of rapid breathing or chest indrawing, no history of vomiting, abdominal pain or loose stool. There is no history of weight loss, decreased appetite or jaundice. There is no history of rash over skin and any skin lesion. No history of altered sensorium, seizure or weakness of limbs.
Dr. Naresh, I think we can have a question also along with your presentation.
Yes, sir.
So the previous slide, next slide. So you have asked these questions. What is the basis of asking?
Sir, because child is presented with complaint of fever and duration is 6 days. So to rule out the any other systemic involvement for the fever, I asked the cough and cold, rapid breathing, chest indrawing for the respiratory infection, history of vomiting, abdominal pain, and loose stool for the GI involvement, most common acute gastroenteritis, weight loss, decreased appetite, and jaundice, which is related to hepatitis, or history of rash over skin and skin lesion, which is for the any inflammatory cause like lupus or Kawasaki disease. No history of altered sensorium, seizure, weakness of limb, that is related to CNS, uh, an infection related to CNS system.
So I think basically what you are trying to say that these questions are being asked to find out what could be the cause of fever, right?
Yes, yes, sir.
So do you think that you should be including your diagnosis as lupus or Kawasaki in this patient?
Uh, Sir, because it is a 6 day fever.
So any
Kawasaki.
child who has got fever for 6 days, will you think of lupus
No, sir, it is
and
just.
no other complaint?
Yes, sir. Because fever will be of long duration and other complaint will be there for the
So the
inflammatory.
for lupus, the fever may be prolonged and
Yes,
they may be having joint pains. Then again, as the fever is prolonged, then there is a history of weight loss. And lupus being a multi-system disease, other systems may also get involved. So maybe it will not be correct idea to rashes, yes, for any viral fever rash, you can ask the history, definitely. Okay, next.
past history. At the age of 1 year, child had first episode of urinary tract infection with symptom of fever for 3 days and excessive cry during micturition. For that, parents consulted pediatrician and advised for ultrasound KUB that revealed normal findings. And on urine routine microscopy, there were 10 pus cells and urine culture revealed E. coli. For that, oral antibiotic were taken for the 1 week. Similar episode occur at 1.5 years of age. For that, again, antibiotic given and child relieved. There is a history of passing hard stool Family history. There are two siblings. First child is 13-year-old female child, and there is no similar complaint in the first child, and there is no family history similar to complaint of the child. Antenatal history. Mother age at marriage is 25 year. Mother age at conception is 26 year. Conceived spontaneously after 1 year of marriage. First trimester pregnancy detected by urinary pregnancy test. It is a booked case, no excessive vomiting. Dating scan shows normal. Lab folic acid, calcium, and injection TT was taken. No history of bleeding PV. Second trimester, quickening felt at 5 months of age of gestation. Second dose TT taken. Anomaly scan was normal. Third trimester, antenatal scan was normal. Amniotic fluid was adequate. No history of burning micturition in mother. No history of headache, blurring of vision, or pedal edema. No bleeding per vagina, and no premature rupture of membrane. Natal history. Child is a term delivered 38 weeks, born by LSCS. Birth weight was 3 kg, and child cried immediately after birth. No history of NICU admission. Child passed urine and stool normally after birth. According to modified Kupuswamy classification, this family belongs to upper middle class. Development history. Child achieved all the milestones as appropriate for age. Gross motor neck holding at 3 months, rollover at 5 months, and sit in tripod position at 6 months. Bidextrous approach at 4 months, unidextrous at 6 months. Social milestone, social smile at 2 months, recognize mother at 3 months, and stranger anxiety at 6 months. Language, who's at 3 months, laugh at 4 months, and monosyllable at 6 months. Immunization history. Child is immunized completely till date according to national immunization schedule. Nutritional history. Child was exclusively breastfed till 6 months of age, and then started complementary feeding, and now child is on oral kitchen feeds along with family. Calorie intake is 1100 kilocalorie, which is expected 1000 kilocalorie. Protein is 15 gram per day, and in expectation of 14 gram. There is no deficit in calorie or protein. Summary. 22-month-old female child born to a non-consanguineous marriage with a history of fever for 6 days and increased frequency of urination along with foul-smelling urine. With past history of 2 episodes of UTI in the past and history of constipation.
Dr. Naresh, can you go back to the slide where you have mentioned history of passing hard stools? Yeah. So here, at one place you have mentioned that oral antibiotics were given for 1 week,
Yes.
right? Is the duration all right, or should they have been given for a lesser period or more?
No, sir. They have taken 1 week antibiotic.
No, but this duration recommendation is fine.
Sir, generally 7 to 10 days.
Okay, yes, you are right. 7 to 10 days. And if the patient is perfectly fine, then maybe 7 days is enough.
Yes, sir.
But younger the child, the duration should be little more.
Yes.
Right. And you have mentioned history of passing hard stool. You have not defined anything more than that. What else you should have done?
Uh, we can ask for uh, frequency frequency of stool and
Hard stools means, in other words, you are saying that there is constipation, and this has been there for how long?
sir, exact duration I haven't asked the duration, but uh, there is a history of hard stool.
And
Widely speaking, or
any application of force while passing How many times the child was passing stools per week, or any classification criteria
Sir,
of saying that these stools are hard? Bristol classification.
Ideally speaking, you should have shown the Bristol stool chart and asked how hard are they? Whether
yes,
the child passes stools on a daily basis or not, what is the frequency, the child has a stool pattern or not, that on so and so time does he pass, or it's a randomly. So these are things that you are supposed to ask, whether he passes blood in stools along with the hard stools.
yes,
And why is
Like
it
you
so
are,
important to
while you are always asking for a micturition problem, you are asking for bladder diary. So
Hmm.
similarly, a diary can be maintained for bowel diary also. So all these things will come into that bowel diary. How
yes,
many times, hard, soft, Bristol classification. So that is very necessary, because passing hard stool once is doesn't mean there is constipation,
yes,
right? So you should have elaborated more on this.
yes.
Okay.
Dr. Naresh, why is it asking for the history of constipation important in a child with recurrent UTI?
Sir, because constipation is one of the risk factor for the urinary tract infection due to bowel bladder dysfunction.
What is bladder bowel dysfunction? What is it?
Sir, uh, abnormal voiding of the urine in the like more of frequency.
Naresh, as
So,
the name says, bowel, bladder. So both the
that's fine.
bowel is involved, bladder is involved, right?
Yes,
For bowel, there is constipation. Again, we have already discussed when do you say it is constipation. And then bladder problem means there are all sorts of bladder dysfunctions,
yes, sir.
like daytime wetting, increased frequency, increased urgency, dribbling. So all these are bladder dysfunctions. And any investigation to say that the patient has got
Sir,
bladder dysfunction.
first we have to establish the normal. Well, there is no any congenital or anatomical urinary tract abnormality related to bowel, bladder and patency of neuronal.
See, bowel bladder dysfunction is quite commonly associated with VUR, vesico-ureteral reflux.
Yes, sir.
Right? So that is one of the very common associations. And by ultrasound, you can see that the bowel, that the bladder wall thickness is there,
Yes, sir.
right?
Volume and thickness. If there is more than 20 ml of post-voidal volume or more than
Mhm.
3 thickness of bladder wall in empty
Yes,
bowel or more than 5 in full bladder or
correct.
more than 6%, 10% of the post voiding volume, that is
You can say in
ultrasound.
a
Right.
nutshell, it can be a thick bladder. You can, in a nutshell, the dimensions are different, but thick bladder, significant post-void residue, associated hydroureteronephrosis, and a increased transverse rectal diameter. These are all hints on an ultrasound that the child may be having a bladder bowel dysfunction.
Yes,
So my reason of asking the question was what is bladder bowel dysfunction is because the emphasis comes on the fact that it is right from the embryonal perspective. This becomes important because in the as an embryo, the you can say the genital tract and your the alimentary tract, they are all common. That is the common cloaca. So since they have developed from the same base, the neural supply is also same. Hence, elimination problems of one will have elimination problems in the other tract also. So that forms the basis of that bladder bowel dysfunction. Okay, so one may be having a structural defects, like in your child with recurrent UTI, maybe there's a reflux and also structural defect. So on the other side, you may have functional defects. So if it's a loaded rectum which is compressing the bladder from top, so problems will be increased frequency of urination, like an overactive bladder. If this same fecal loading, or the you can say the loaded rectum compresses the bladder outlet, so your problem will be urinary hesitancy. There will be significant postpartum residue, again increasing the chances of UTI in the child. Hence, pickup of bladder bowel dysfunction is also important, and you have to co-manage it. Unless you manage it well, this child will continue to come with recurrent UTIs and eventually may lead to scarring of the kidneys. Hence, a pickup has to be there. Well, you may have to ask leading question to actually pick up the child has constipation or not, because half the parents do not agree to the fact the child is constipated. Hence, you have to show them pictures of Bristol stool chart, ask them what kind of stools are you passing, along with the bladder diary, as Dr. Puthi told, maintain a stool chart also, so that in a nutshell you can treat the child in a holistic manner.
Yes, sir.
All right, you can continue.
General physical examination. Pulse rate is 110 beats per minute, which is regular. Respiration RR is 26 beats per minute, which is the abdominothoracic type. Saturation is 98% on room air. Peripheries are warm. Temperature is 98 Fahrenheit in right axilla. Peripheral pulses are well felt. CRT is less than 2 seconds. Blood pressure is between the 58 to 90th centile in all four limbs. Anthropometry, according to WHO chart, weight is 10.4, which is between 15 to 50th centile. Height is 86 centimeter, which is 58 to 75 centile. Head to toe examination. There is no pallor, icterus, clubbing, cyanosis, or lymphadenopathy. Hair are normal in texture, no facial puffiness. Eyes, no epicanthal fold, hypertelorism. Ear, no low set ear or auricular tags. BCG scar present. Genitalia, no labial adhesions. Spine normal, no dimpling or tuft of hair. Limbs, no bony deformities. Skin is normal. Systemic examination for abdomen. On inspection, shape is normal, flanks appear normal, umbilical position is in center with no discharge. All quadrants move equally with respiration, no visible pulsation. Skin over the abdomen appear normal, no distended veins. Hernial orifice appear normal, and external genitalia normal. On palpation, abdomen feels soft on palpation, no tenderness. Local temperature is normal and no organomegaly. Kidneys not palpable. On percussion, resonant not heard. On auscultation, vowel sound are present. Respiratory system, symmetrical chest appearance, no chest deformities, apical impulse could not be seen, no increased work of breathing, retraction, nasal flaring. Examination of back, spine is normal, interscapular distance is bilaterally equal, no drooping of shoulder, winging of scapula. On palpation, chest tenderness, there is no chest tenderness, no crepitus. Apex bit felt in left fourth intercostal space in mid-clavicular line. Auscultation, bilateral air entry equal, normal vesicular sound, no added sound. On CVS examination, normal precordial bulge, apical impulse not seen, no chest deformities. On palpation, no precordial impulse felt, no parasternal hive. Auscultation S1, S2 is heard, no murmur. CNS examination is normal, conscious, alert, active, no cranial nerve abnormality. Motor system examination, bulk tone normal in both upper and lower limbs, moving all four limbs. Bilateral knee jerk reflex present and bilateral plantar going down. Provisional diagnosis is 22 months old female child born to a non-consanguineous marriage with history of fever for 6 days, increased frequency of urination and foul smelling urine with history of 2 episodes of UTI in the past with history of constipation. So provisional diagnosis is recurrent UTI. Course in hospital. Blood investigation shows hemoglobin of 7.5, TLC 37,570, platelet 6 lakhs. Renal function test shows normal B1 create, sodium, potassium normal, calcium 9.06 normal, phosphorus, protein and albumin are within normal range. Urine routine microscopy shows pH of 7, protein negative, nitrite negative, glucose normal, pus cell 16 per high power field, RBC 4 per high power field. Child has been started with IV antibiotic monosep at 100 mg per kg per day, started in 2 divided doses. Other supportive treatment, IV fluid and antipyretics given. Fever subsided after 48 to 72 hours of admission. Further imaging workup had been done in view of recurrent UTI. Ultrasound of abdomen shows normal finding. Both the kidney are normal in size, position and outline. There is no dilatation of pelvic calyceal system or calculi on either side. MCU was done, which shows right side grade 4 vesico-ureteric reflux and left side grade 5 VUR. DMSA scan was done.
Naresh, can you show the scans?
Sir, MCU scan is not available.
Ultrasound?
DMSA scan was done, which shows left kidney is normal and the renal cortical contour is regular with no focal cortical defects seen. Cortical trace uptake is good and homogeneous in entire kidney. Right kidney is relatively small in size, normal in placement. Renal cortical contour is irregular. Flattening with loss of cortical volume is seen at both the poles. Renal cortical tracer uptake is preserved and inhomogeneous in rest of the kidney. Function, differential renal function, left 49.3% and right is 50.61%. So the finding is related.
Why did you get these investigations done? Patient has got just UTI. You treat the patient and send him home.
Sir, because
Why do you want these investigations?
And even the ultrasound is normal. So why do you want DMS and MCU?
sir, because of, yes,
Even ultrasound also. Why did you get an ultrasound?
sir, because history of recurrent UTI, there are 3 episodes in last 1 year. So according to guideline, we need to ultrasound and MCU. And according to MCU, if there is a VUR, then we have to go for DMS scan. So we have
what would you have? This ultrasound is normal. What would you have expected had this ultrasound being not normal? Now you know MCU shows bilateral reflux, grade 4 and 5. What would you have expected in ultrasound?
Sir, size of kidney, obviously, right kidney is smaller, so the size of the kidney should be smaller on ultrasound. And pelvic calyceal system, because there are VUR shows grade 4 and grade 5 VUR, so pelvic calyceal system should be impaired, abnormality should be there.
So in short, you could have said pelvic calyceal system dilatation,
Yes, sir.
ureteric dilatation, so bilateral hydroureteronephrosis, right? And then what about the other anything else you would have liked to see in ultrasound? You have seen pelvis, you have seen the calyces, you have seen the ureters, you have seen the bladder.
Bladder.
You've seen, as per you, is the ultrasound report complete or there's something missing?
No, sir, bladder. Just they have mentioned urinary bladder shows normal wall and ligament. So we can post-vidal volume, we can see that. And
So ideally speaking, in a
thickness
full
of,
bladder state, you're
yes,
supposed to have the pre-void volume, then the post-void volume, and then the bladder wall thickness. And
yes,
at times, if you do the dynamic ultrasonography, you can even say in the full void, in the pre-void state, when the bladder is full, what are the dimensions of the pelvis? And in the post-void state, how much does it decompress? How much does it come down? So you can comment on that. But provided you have a full bladder and an empty bladder ultrasound. Yeah.
yes, sir.
Also, you have to see the cortical thickness also,
Yes.
because it may be thin.
Mm.
So these are the sort of ultrasound findings. Then on MCU, you have mentioned. And why did you get an DMSA?
Uh, Sir, because MC shows grade 4 and 5 uh, VUR. So according to guideline, if there is a high grade VUR, so that we have to see the scarring of the kidney.
What should be the time when DMSA is to be done?
Ideally, sir, after 3 to 4 months of u urinary UTI episode.
Okay, why? Why 3 to 4 months?
Sir, because sometime pyelonephritis also shows the same feature of
No, that is not the answer. The answer is that it takes around 4 to 6 months for the scars to properly develop,
this.
right? So once there is UTI, UTI means pyelonephritis, then it may take around 4 to 6 months. So if you get an DMSA earlier, you may not be able to see the scars. So getting an MCU earlier will be futile. But in this patient, you have got it very soon. As soon as the patient has come to you and you have got the EMS scan, the reason for that is this patient has been having recurrent UTI.
Yes, sir.
So, and the past history is that the child had UTI at the age of 1 year.
Yes,
So
sir.
almost 1 year has passed, and within that 1 year, he would have developed established scars. So that is the reason why we could get the DMSA so soon. Otherwise, the recommendation is after 3 to 6 months from an episode of UTI. Okay.
Yes, sir.
All right.
Dr. Naresh, can you go back to the urine routine slide? Where you mentioned that the nitrite was negative and the pus cells was 60. So what is the significance of nitrite?
Sir, nitrite produced by the bacteria um, uh, that like gram negative bacteria present in bladder that will produce a nitrite. So that would, if there is a bacteriuria, then nitrite would be positive, sir. But
So
How
basically,
here,
you can
about
say if it is
leukocyte estrase? You have not even mentioned that.
sir, leukocyte esterase was not done, sir. Just urine routine.
What would you have expected in this patient?
Sir, leukocyte esterase would be positive because pus
Positive.
cell are
Okay.
60. So that,
So these are indicators of infection. You can diagnose as soon as the patient comes to you and you get a urine sample, do this dipstick test, and you know whether the patient has got UTI or not. Okay.
yes, sir.
So both these tests have their own significance, their sensitivity and specificity. So I think you will discuss that later on.
Sir, deep stick test is used as screening or on the spot test, which can there are two tests: leukocyte esterase and nitrite. Leukocyte esterase has approximately 80 to 90% of sensitivity and specificity, and nitrite test has low sensitivity and more specificity. So the combined leukocyte esterase and nitrite will be a better choice for initial spot test. Or
So if you combine all three urine microscopic examination, nitrite test, and leukocyte esterase.
Yes,
Then the pickup rate goes up to even 95%,
yes, sir.
which is quite comparable to the culture.
Yes, sir.
And culture is the gold standard.
Uh,
So this is a sort of test which you can do in immediately as soon as the patient comes and the child is able to pass urine.
yes,
And you can start the antibiotics because it is very essential that you diagnose this patient at the earliest and start the antibiotics at the earliest,
yes, sir.
right? Okay, anything else?
There's a question from the delegates who are attending. Is gross hematuria commonly seen in UTI in infants?
Sir, if there is a cystitis, then only gross hematuria can be there. Otherwise, hematuria will be gross hematuria will not be seen in UTI.
So usually it is rare to have gross hematuria. Microscopic still can be there, but gross is pretty rare. Yeah. Or you may, if you have an associated, like you can say UTI with some crystalluria or calculi disease. In
Yes.
those scenarios, gross hematuria are more common. Yeah.
Already in blood investigations, what else you could have got done
Sir, we can
to
see
diagnose UTI?
we
In
can
addition to, you see, you got the urine examination, microscopy, dipstick test, urine culture. Have you mentioned urine culture report?
no, sir, urine culture
No,
not mentioned.
Mm. What was it?
Sir, urine culture was negative. Our in Gangaram Hospital, sir. It was.
And how do you explain that?
Sir, actually, a child has taken antibiotic outside the previously to admission.
Okay,
Started antibiotic on 3rd of the July and admitted on 8th of the July. So
right. So this is one situation
yes,
when patient has taken antibiotics, is having UTI and culture is negative. That you should remember. Hmm. And
so
regarding the leukocyte esterase test, the patient may be having leukocyte esterase test positive and there is no infection. So what are the reasons for that?
sir, in glomerulonephritis and foreign body in urinary tract or renal stone or any febrile illness, all this condition can cause a
Yes,
asymptomatic
interstitial nephritis
interstices.
and sometimes in hypercalciuria.
Yes, sir.
Mm, because then they are losing these leukocytes in the urine,
Yes, sir.
right?
there should be any stone disease or crystallurias, or even if you have stents, okay, internal nephritis, glomerular nephritis, all of them can have, you can say what is called a sterile pyuria. Pus cells will be there, leukocyte esterase will be positive, but it culture may be sterile. So that is not UTI. So once you have done with your treatment of UTI, do we need to repeat a urine culture?
No, sir. Urine culture is not recommended after treatment.
Hmm.
Sir, we can do a ultrasound KUB after 48 to 72 hours of antibiotic if fever is not subsiding or symptoms are persistent to rule out the pyelonephritis or renal abscess pyelonephritis. Urine culture is not advised.
And when do you repeat a urine culture? What are the indications to repeat a urine culture during your course of treatment?
Mhm.
When do you repeat?
Sir, in case of uh, low colony growth on urine culture and you are suspecting strong suspicious of UTI, other is
Fine.
persistent of UTI symptom and fever after 72 hours of sensitive antibiotic
Fine.
Uh,
Last. Now, if the recurrence of symptoms means you are giving a sensitive antibiotic, the symptoms went off, the child became afebrile, and maybe after 2 or 3 days, you're still on the same antibiotic and it starts spiking fever again. And urine routine, which may be showing less pus cells post treatment, has suddenly increased, the pus cells have increased. So, where you suspect that there is a recurrence of the UTI while on the treatment with that same sensitive antibiotic, then maybe you can think of repeating a urine culture.
yes.
Dr. Nilesh, you have to have something for discussion also, or
Yes, sir. I have
okay, then you can go through those slides.
sir, recent ISPN 2023 guideline for the recommendation of UTI, evidence-based clinical practice guideline for management of UTI and primary VUR. Definition of UTI, infection of urinary tract diagnosed based on growth of single uropathogen with significant colony counts in presence of symptoms. Risk factor for UTI are constipation, neurogenic bladder, labile adhesion in girls, phimosis in boys, and obstruction. Clinical symptoms and signs according to age of child. If less than 2 months, there are generalized symptoms like fever, vomiting, irritability, lethargy, poor feeding, failure to thrive, jaundice, hypothermia, and hematuria. 2 months to 24 months, uh, as the age increases, the localization of symptom will be increased. So abdominal pain, frequency, malodorous urine and cloudy urine will be there in 2 to 24 months. More than 2 years, dysuria, incontinence, hematuria, suprapubic pain, low in pain and tenderness will be there. Some physical examination which are important, palpable kidney or poor urinary stream to rule out the obstructive uropathy or neurogenic bladder. Costovertebral angle tenderness will show pyelonephritis. Palpable bladder, suprapubic tenderness, obstructive uropathy or neurogenic bladder. Palpable fecolid to see the constipation. Sacral dimple, tuft of hair, lipoma, abnormal neurological evaluation of lower limb, and abnormal perineal sensation which show occult meningomyelocele. Sample collection method. If child is toilet trained, we have to take clean catch method. Non-toilet trained children, we should attempt the clean catch initially, and if not, then we should go for catheterization or suprapubic aspiration. For sick infant, catheter or suprapubic aspiration will be done. Perineal cleaning with soap to decrease the contamination recommended, and catheterized sample better to take late stream urine. First line screening test, urine dipstick test, leukocyte esterase and nitrite combination, urine routine microscopy in fresh voided sample, alternative to dipstick. In infant less than 6 months of age, we can start empirical antibiotic despite of negative nitrite test, but high suspicion or presence of risk factor. For confirmation of diagnosis, urine culture is the gold standard. Fever without focus more than 42 hours, age less than 24 months of, and presence of risk factor. So any specific urinary symptom, perform urinary culture and dipstick test. If leukocyte esterase or nitrite is positive, start empirical antibiotic. If child is less than 6 months and risk factor are present and test is negative, we can start with antibiotic if risk factor are there. Otherwise, we have to wait for the culture. And finally, according to urine culture report, continue antibiotic or stop antibiotic, or we can start antibiotic if not started earlier. Diagnosis confirmed by significant growth of single bacterial species on urine culture in presence of symptom suggestive of UTI. Significance mean suprapubic aspiration more than 10 power of 3, catheterized sample 10 power of 4, and clean catch 10 power of 5. Leukocyturia alone is not a UTI. It can be seen in glomerulonephritis, kidney stone, foreign body in UTI, urinary tract, and febrile illness. Treatment. Antibiotic therapy should be initiated within 48 to 72 hours of onset of fever. Early initiation showed to reduce morbidity and kidney damage. Empirical antibiotics, cephalosporin or amoxiclav, cotrimoxazole associated with recurrent UTI. Prefer oral over IV antibiotic except in infant less than 2 months of age, severely ill patient, or patient who are unable to ingest antibiotic orally. So once a urinary tract infection, if there is a cystitis in adolescent, we can give oral antibiotic for 3 to 7 days of duration. Febrile UTI or pyelonephritis and child is less than 2 months, sepsis, renal angle tenderness, poor oral intake. If all these symptoms are present, then we have to give IV antibiotic for 3 to 4 days initially and then oral. Otherwise, we have to start oral antibiotic only. According to clinical response, if started IV antibiotic, we have to switch to oral if clinical response is good. Recommended changing of initial antibiotic only if clinical treatment failure. If fever persists for more than 48 to 72 hours, re-evaluate with USG ultrasound KUB. In acute symptomatic UTI, duration of treatment is 7 to 10 days. In cystitis, duration is 3 to 7 days. In symptomatic bacteriuria, given treatment only if instrumentation is being done. In kidney allograft recipient for initial 2 months, and there is no data to support in immunodeficiency and diabetes. Imaging in UTI, USG KUB should be performed after first episode of UTI. If there is no clinical improvement within 48 hours of antibiotic therapy, the ultrasound KUB should be done to rule out the pyonephrosis, renal or perirenal abscess. In case of first episode of UTI, assess the bowel bladder dysfunction and do a ultrasound KUB. If it is normal, then there is no need of follow-up. If it is abnormal, then only do a MCU. In case of non-E. coli UTI and age is less than 2 years of age and recurrent UTI, then only go for ultrasound along with MCU. If MCU shows VUR grade 3 to 5 and symptom of recurrent UTI, then only DMSA is indicated after 4 to 6 months of UTI episode. MCU should be done in UTI caused by non-E. coli uropathogen in children less than 2 years, abnormal ultrasound, and history of recurrent UTI. DMSA scan after 3 to 6 months to assess kidney scarring in children with recurrent UTI or high-grade VUR 3 to 5. Prevention of UTI. In absence of bladder bowel dysfunction or normal urinary tract, antibiotic prophylaxis is not recommended. Recommend prophylaxis in high-grade primary VUR grade 3 to 5 for prevention of recurrent UTI. Risk of recurrence of UTI in high-grade VUR is 2.7 times higher than the low-grade. In infant with recurrent febrile UTI and low-grade primary VUR, we can consider antibiotic prophylaxis. Antenatally detected hydronephrosis, which is waiting for evaluation, there is no need of prophylaxis. For prophylaxis in children older than 3 months, we have to give cotrimoxazole or nitrofurantoin, first-line drugs. Bacterial resistance is more with cotrimoxazole, so nitrofurantoin is preferred. If child is less than 3 months, cephalexin is preferred. Prophylactic antibiotic can be discontinued in children older than 2 years of age if child is toilet trained, there is no bowel bladder dysfunction, and no febrile UTI in last 1 year. Studies have shown that recurrent rate of UTI is same before and after antibiotic causation if patient age at discontinuation is more than 2 years. Routinely used antibiotic for treatment, amoxiclav, cefixime, cefuroxime, cephalexin, cefodoxime, and ceftriaxone, cefotaxime, ciprofloxacin, oflox, amikacin, and gentamicin. For prophylaxis, quatrimoxazole, nitrofurantoin, cephalexin, cephadroxil, and amoxicillin. If child is less than 3 months, quatrimoxazole and nitrofurantoin should be avoided. In case of G6PD deficiency or renal function deranged, we have to avoid quatrimoxazole and nitrofurantoin. Circumcision can be considered in patient with high-grade UTI or recurrent UTI for prevention. It decreases recurrence of UTI by 82%. Recommend cranberry product for prevention in recurrent UTI, and normal urinary tract have proanthocyanins, which are protective, prevent adhesion of pathogen to urothelial cells. Bladder bowel dysfunction, important risk factor for recurrence of UTI. Clinical evaluation include 2 days voiding diary. If it is less than 4 or more than 7 voids per day, it is abnormal. Detail of bowel movement over 2 weeks. First line of management is urotherapy. In toilet trained children, if don't respond in 3 to 6 months, do a uroflowmetry. Treatment of bowel bladder dysfunction. First line is urotherapy and bowel regimen. Second line is overactive bladder, dysfunctional voiding, and underactive bladder. We have to go for oral drugs like oxybutyn, tolterodine, mirabegron, tamsulosin, doxazosine, and underactive bladder, clean the intermittent catheterization and biofeedback therapy. Third line is botulinum toxin. Urotherapy is basically voiding diary, increase fluid intake, 6 to 8 cups per day, reduce intake of caffeine and chocolate, frequent 2 to 4 hourly double voiding, adequate posture, support both feet on stool or flat surface. Primary VUR management. High-grade VUR treat with antibiotic prophylaxis. If recurrent episode of UTI more than 2 episodes, despite on antibiotic therapy, we can consider surgical reimplantation. If consider surgery, prefer to do open ureteric reimplantation over endoscopic correction. Primary VUR, if a low grade 1 or 2 and there is no UTI, so no need of antibiotic prophylaxis. Low grade VUR with UTI and bowel bladder dysfunction, then only antibiotic prophylaxis is indicated. In case of high grade VUR 3 to 5, antibiotic prophylaxis is advised irrespective of bowel bladder dysfunction. And if recurrent UTI on antibiotic prophylaxis, we have to do ureteric reimplantation or endoscopic injection. Follow-up in VUR. Follow-up to prevent reflux nephropathy, which can develop later. It is defined as presence of photopanic area and contour changes on DMSA scan. Risk factor are older children with VUR, recurrent symptomatic UTI, and VUR with bowel bladder dysfunction. Complications: hypertension, proteinuria, and chronic kidney disease. USG to be repeated annually in high-grade VUR. If recurrent UTI, consider DMSA scan. Repeat MCO only planning for surgical intervention 4 to 8 years after initial diagnosis in high-grade VUR. Follow-up is required till 4 to 8. Screening of siblings. If age is less than 3 years, patient with primary VUR, ultrasound KOB is advised. Thank you.
Any questions from the participants?
So, Dr. Naresh, in your child who has this bilateral reflux and a unilateral scar,
Yes,
so
sir.
how do you want to follow up your child, which you have presented? Well, whether you want to do a surgery or not, you just want to follow them up. How frequently do you want to do an ultrasound? Just summarize.
Yes, sir. Generally, sir, we give option to parents whether they want a surgical intervention or oral prophylaxis or oral antibiotic. Uh, so if we start with oral prophylactic antibiotic, and then even after then recurrent UTI episode happens or any scarring will be seen, then we can go for a surgical intervention. Sometime initially we can do a surgical intervention if parental consent is there.
And in case you want to wait, you wait till what year before you operate?
Mm.
Well, there's no recurrent UTIs, child is doing well on prophylaxis. The
Yes,
parent asks you, how long can I wait before I consider for a surgery?
sir, we can wait up to age of 4 to 8 years.
You can wait till average around 5 years.
Yes,
Okay, but then again, you have to remember post 5 years, the normal question is in case there's a child who does not have recurrent UTIs, you have stopped your prophylaxis, child is doing well, there is no progression of scarring. Okay, and if it's a boy child, so you can just ask a boy or a girl, you can just ask them, okay, you do not want to go for surgery, you can wait. And but remember that in case a child develops a UTI in future, there is a risk of progression of the kidney damage or new scars.
yes, sir.
Okay. But from the girl's perspective, you have to remember that whenever the menses start off or the pregnancy comes in, the chance of recurrent UTI again starts off. So normally from the female perspective, you can actually tell them that future these are the issues that can come up. So in case they want to go for a surgery early, it's fine. But from the boys' perspective, usually they do not have any recurrent UTI. They're doing well. Okay, so less chances that they'll have troubles in the later in life. But the parents should be aware of the fact that yes, if a UTI comes in, the risk of scarring is still there, or risk of kidney damage is still there. It should not be that you have asked us to wait and then the kidney damage did not. And that is the reason why we did not go for surgery. So at the end of the day, you have to give the parent an option that you choose whether you want to continue on prophylaxis or you want to go for an early surgery. Post that, once the prophylaxis period is over, then before stopping the prophylaxis, again you can ask them for an opinion whether you want to stop the prophylaxis and wait and watch, especially in a child who's doing well, or do you want to go in for a surgery.
Thank you, sir.
Dr. Naresh, if this child is, you have said that VUR and recurrent UTI, let's say this child had an elder brother or sister, let's say 5, 6 years old, what
Yes,
advice you would have given?
sir. In case of VUR, there are 30 to 40% of chances that sibling will get a VUR, primary VUR, in case of primary VUR. So we advise ultrasound KUB, but new recommendation is that if child is less than 3 year, then we advise ultrasound only.
Yes. That's a new recommendation is that you advise ultrasound
Yes,
less than 3 years. Or if the SIB has got UTI,
yes, sir.
has had UTI or was having recurrent UTI, then they should be thoroughly investigated.
Yes, sir.
I'll tell in like commenting on the same question.
Yes,
Basically, in reality, what had happened was this patient's father asked a similar question. That the elder sibling is 12-year-old. So he asked what maximum can I do to screen that child. So we asked them for an ultra. I said you can do an ultrasound maximum. So he said in this child also the ultrasound was normal and still reflux was there. So shall I do an MCU for this child or not? For the other sibling.
Yes.
So now what's your advice? Shall we do an MCU for all children who even have a normal kidney ultrasound, or how
If
do you approach?
sir, we should wait, not to wait, but if there is no any episode of UTI,
Mhm.
then there is no need of MCU.
Fine. So basically, it is if it's an asymptomatic child with a normal ultrasound, need not go in and do an MCU for those children. But
Yes.
if you had a history of, you can say, UTI in the past, then definitely you can advise them for an MCU in case there is some problems there.
Why you are not getting an MCU? These, according to these recommendations, the reason is that if ultrasound is normal, even if the patient has got reflux, the grade of reflux will not be very high, and the causes of scar getting found will be less. So the basic idea is to reduce the frequency of doing these MCUs, and which is considered to be invasive procedure and causing radiation also.
Yes.
So these recommendations are there only to reduce the frequency of doing MCUs. And earlier on, the recommendations were different, and many more MCUs were being done,
Yes.
right?
Okay, sir.
I think we have presented very well, and some of the things now which have been discussed, you should remember.
Yes, sir.
Okay.
Okay.
Thank
So,
you. Thank you very
so
much.
before so before we end, there's one more question from the participants. It is like the last question. If confirmed UTI in a 12-year-old female with culture positive for Klebsiella and on treatment on cefixime for 7 days, but fever is still persisting, and the culture says resistant to ceftriaxone, but sensitive only to amikacin, what should be the next step? Should we add second line, and what we should do?
Sir,
So basically, uh, uh,
sorry, sorry, sir.
so in this scenario, I'll suggest that in case you're on cefixime and the child is not responding to cefixime, and you have a culture in hand which says sensitive only to amikacin, definitely you can add amikacin to the child. But
Now,
taking it the other way around, if
what were the symptoms in this patient, and what was the urine report? And then only we can proceed. Just by saying that the patient has UTI, we have to
uh,
know what was the criteria of diagnosing UTI, whether
UTI.
there were any symptoms were there or not, whether it is asymptomatic bacteriuria. So these are some very important questions which need to be answered before you
Sir,
proceed with the
they
treatment.
are saying proteus growth in urinary culture, sir.
No, growth is all right. Is the patient having any symptoms?
They sent fever only fever is there. Urine
Fever
routine,
is
they have not written any report.
Mhm. Because
Only
you see,
fever, urine culture, Klebsiella positive.
mm,
Yes, Pepsi.
no, if you are sure that this is UTI, and
Hmm.
since the patient is having fever, and we have to be very, very, very clear in this patient that there is no other cause of fever
Fever.
which we could find out. So then only we can say that now, yes, this is UTI, and then you have to give antibiotic according to the culture report.
Hmm. So taking the things the other way around, in case you have started cefixime and cefixime comes resistant in the culture, but child has improved symptomatically, then you should continue giving cefixime only. Need not change the drug again, as per
Yes,
the sensitivity.
that
Yeah.
is right. But if the patient has not improved symptomatically, then
Then
you can.
definitely you need to change. Yeah.
Yes. If in this patient, if fever is persisting, then you need to change.
Yeah.
I think we can conclude now.
You can.
Thank you. Thank you, Dr. Naresh.
Thank you, sir.
So good presentation, Dr. Naresh. Yeah.
Thank you, sir.
Thank you, all of you.
Okay. Sir. Good night, everybody.